Assalamu alaikum. Good morning, everyone. We don't have any cases for this month's CTR, so I was supposed to present the CTR cases, so instead I prepared a presentation. Before we start, I'd like to wish you all a happy 89th National Day. And I'd like to seize this opportunity to remind us all to work hard and to drive the future and shape the future of our country. Our country is going through major changes recently, and the major driving force of those changes is not oil, but youth. They say that 70% of the Saudi population is 30 and below. Unfortunately, I just passed my 30th birthday earlier this year, so I'm not part of that 70%. But I guess all generations, young and old, will drive our country to a prosperous future. I'll remain young at heart. Cataract and glaucoma surgery, simultaneous versus sequential. This is what I'm going to be talking about over the next 30 to 40 minutes. I'd like to dedicate this presentation to Ahmed and Baerveldt. Part of our daily routine, Brahim and I, is to argue over lunch break, over surgical decisions that we made during that day. You know, arguments like, why would you combine a trab with a phaco? You will reduce the effectiveness of the trab itself. It's common sense not to do trab and pseudophakia because trabs don't work well in pseudophakics. Well, common sense is actually a myth, not a reality, for two main reasons. A, it's subjective. What might seem common sense to me may not seem common sense to you. So it's actually not common. And B, it changes according to your knowledge base. What may seem common sense to you today may not seem common sense to you after 2 or 3 years after your knowledge base changes. So it's actually nonsense rather than being sense. With that being said, those are the outlines of the presentation. I'll start with a brief introduction. Then, second part, I'll talk about doing glaucoma and cataract surgery simultaneously at the same setting. And in the third part, I'll be talking about sequential glaucoma surgery, one first, then the other, and then we'll conclude. Cataract and glaucoma. I wish managing them was as easy as our patients think. نسحب الموية البيضاء ونسحب الموية الزرقاء and we're done. And unfortunately, it isn't. Sometimes this is visually significant, but this is under control. And in other instances, this is uncontrolled, but this is not visually significant. And in other instances, this is visually significant, and this is also not controlled. And if you operate on this only, IOP reduction may not be enough to control this. And if you operate on this only, you may get cataract progression, and this might be visually significant. And if you do both of them together, you might get an outcome that's not that much predictive. So what's the optimum solution? We'll have a look after this presentation. Maybe the optimum solution would be not doing anything at all. There are different scenarios if we want to talk about cataract and glaucoma. And some of those scenarios were actually discussed in previous CTRs. Sometimes you have visually significant cataract and the glaucoma is controlled on meds. And this is probably where all the MIGS space is. And sometimes the patient has narrow angle glaucoma and the cataract is contributing to that. And Ibrahim nicely covered that in the CTR last month. So I won't be talking about these two. I'm going to be focusing my presentation on cataract and open angle glaucoma with special emphasis on advanced glaucoma. And the reason why I'm going to make more emphasis on advanced glaucoma is because that's what we see in a huge percentage of our patients. So before I start my presentation, I'll present a clinical case, and I'd like to take your opinion on it. So this is a 60-year-old male with primary open angle glaucoma, no prior history of glaucoma surgery, and he's medically free. Visual acuity is 20/50, pressure is 21 on full topical medication. He's got +2 nuclear sclerotic cataracts, and his cup to disc ratio is 0.9. What's your preferred surgical approach? We've got 4 options. Phaco plus minus MIGS, doing glaucoma surgery, and here I mean major glaucoma surgery, a trab or a tube or a DS. Phaco plus glaucoma surgery, or you're unsure. I'll give you 10 seconds or 15 seconds to take a look at it and give it a think, and then I'll take a vote. Okay, who votes for phaco plus minus mix? Raise your hand. One only. Who votes for glaucoma surgery? Raise your hand. One only. Who votes for phaco plus glaucoma surgery? 4. Danny, unsure? Okay, so at the end of the presentation, I'm going to repeat the same question, and I'm going to take your answers again and see if your mind has changed after discussing what we have to go through. And it's not amazing that you guys have split on your answer. The same question was asked in a recent survey to AGS members, and these were their options. Actually, they didn't say that the glaucoma was advanced or not, but they asked them, what's your preferred approach for phaco, for cataract and primary open-angle glaucoma, and they were splitted between phaco alone, phaco mix, phaco glaucoma drainage devices, and phaco trap. So what are the aims of my presentation? First of all, I'll discuss the effect of simultaneous cataract extraction on the outcomes of glaucoma surgery and vice versa. And from now on, I'll be referring to cataract extraction as CE and glaucoma surgery as GS. And second, I'll outline the considerations that should be taken into account when planning sequential surgeries. And finally, improve our knowledge base with regards to concomitant management of cataract and glaucoma. Okay, so first I'll talk about the effect of concomitant cataract extraction on the outcome of glaucoma surgery itself, and I'll go through procedures one by one. I'll start with trabeculectomy. This is a paper that was published a couple of years ago, 2003, in the British Journal of Ophthalmology. So it's a retrospective study, and they compared trabeculectomy versus phacotrabeculectomy in terms of survival over a long period of time, 60 months. And you can see that the trabeculectomy group, compared to the phacotrabeculectomy group, has a bit of a higher success rate. The mean IOP was 15 in the phaco trab group, and it was 13 in the trab alone group. And when applying a more strict definition of success, the success rate even goes a bit lower. You might say that this is probably a retrospective study and there's no strong evidence from that. This is another prospective study from ACTA in 2013 that also compares trabeculectomy versus phacotrabeculectomy, but the patients were followed for a shorter period of time, 12 months only, and at the end of the first year, it's been shown that phacotrabeculectomy has a bit less IOP lowering effectiveness as compared to trabeculectomy alone. And the question arises after looking at these studies is that, what's the reason behind that? Why do you have lower success rate with trabeculectomy as compared to phacotrabeculectomy? Or sorry, it's the other way around. Well, one possible explanation is that there's an inflammation that's induced by the ultrasonic power of the phaco itself. And this is a nice study that compares the anterior chamber flare in trabeculectomy versus phacotrabeculectomy over time. So this is flare over time. The black dots represent trabeculectomy. So during the first month after trabeculectomy, there's a significant amount of inflammation, but it soon returns to baseline at about 1 month. And then it's maintained that baseline over the whole year. As compared to phaco, the flare goes up, not as significant as trabeculectomy, but the increase is persistent for a longer period of time. And at those 2 points, the difference between the two groups is statistically significant, which is at week 6 and month 3. So doing phaco with trabeculectomy, you'll have more ultrasound power, hence more inflammation. And what about deep sclerectomy? There's actually limited evidence on deep sclerectomy as compared to the vast amount of information about trab, but there's only one study that was published in seminars comparing DS versus phaco DS, and in this study they did not show any difference in terms of IOP reduction, and they also reported similar number of medications, and similar success rate. But this is only one study. Can we conclude that combining DS with a phaco is safer or more effective than combining trab with a phaco? Well, let's not rush into that conclusion, because there's, as I said, limited evidence on DS. And Nitin Anand, which is one of the few British people, or the few people in the UK that do DS, compared phaco DS with phaco trab in a study that was carried over up to 30 months. And they found out that the intraocular pressure control is actually similar between both groups. And there's a slight spike over here in the phaco DS group compared to the phaco trab group. And this, when they correlated this with the clinical course of patients, they found out that this is where most of the laser goniupuncture was performed. This is the survival curve of the same study, phaco DS versus phaco trab. So both groups had the same success rate. The only difference, this is probably something you already know, between phaco trab and phaco DS was that the complications in that study was less in the DS group for one of the complications only, which was delayed blood leaks. They had 7 cases in the phaco trabeculectomy group and no cases in the phaco DS group. Andre Mormont, which is also one of the adopters of deep sclerectomy, also did a study comparing phaco DS versus phaco trabeculectomy, and he didn't find any significant difference in terms of success or IOP control between both groups. The only significant difference was, again, in terms of complications. In this study, they found less hyphema and less inflammation in the phaco DS group. Okay, so we're done with trab and DS. Next comes tube surgery. There's actually limited data on comparing tube alone versus phaco tube. This is one of the studies that compared Baerveldt alone versus phaco Baerveldt. So the combined group is in green, and the not combined group, so Baerveldt alone, is in red. Well, this shows us preliminary data that, well, probably combining a phaco with a tube reduces the success of the tube, but there are many limitations to this study, actually. One is that all the patients in the combined group were pseudophakic, and we know that pseudophakia maybe lowers the success of glaucoma surgery. And the other point is that both groups had statistically significant difference in age. So this age group was younger than this age group, group. So also age plays a role in the success of glaucoma surgery. So this gives us preliminary data that probably combining phaco with a tube may reduce the outcome or the success of tube surgery, but there are potential confounders. Yeah. Less than 22. That's not a good target IOP. Yeah, totally agree. Interestingly, there's no studies doing phaco tube, phaco Ahmed versus Ahmed alone. That would be a good idea for a research, even retrospectively. Okay, so we're done on the outcomes of phaco, concomitant phaco on the outcomes of glaucoma surgery. Now we'll look at it the other way around. The outcomes of doing glaucoma surgery with phaco on the outcomes of phaco itself. So there's no direct effect, and yeah, it's common sense. There's no direct effect if you're doing a phaco with the glaucoma at the same time on the success of the cataract extraction itself. However, with ECP, and probably ECP is not the focus of this presentation, but I thought I'd mention this piece of information. They've noted that patients have, in some studies, not all, some patients have a slight myopic shift, and it's probably related to the position of IOL, especially with laser applied to the ciliary process. But when looking at glaucoma surgeries, and I'm talking about trabs and tubes, in a paper that was published in the Journal of Glaucoma 2015, they also looked at the refractive outcomes following combined cataract with either trab and glaucoma drainage devices. Some positive results. So 74% of patients were within -1 and plus 0.5 diopters. And interestingly, most patients that were outside this range were myopic rather than hyperopic. I was thinking that if you do glaucoma surgery, pressure will be low and the axial length will probably reduce a bit, so you'll have a hyperopic shift, but their findings suggest that it's myopic. Possible reasons is that the astigmatism that's induced on the cornea itself, it changes the corneal curvature, the AC depth changes, so that probably explains their findings. This is another interesting study from Journal of Glaucoma, compared 3 groups in terms of refractive outcomes. Group A, combined phacotrabeculectomy. Group B, sequential phaco, then trabeculectomy, and the last group was phaco alone. And when they looked at the percentage of patients that achieved within one spherical equivalent, it was actually similar, whether you do phacotrabeculectomy or phaco and then trabeculectomy. It's 66%, while in control phacos it's 84%. And in their discussion, they elaborate on the fact that even if the patient has a prior history of glaucoma surgery, the IOL calculation itself is not that accurate. I know I've went through a lot of data, so I'll summarize the findings that we just went through in the first part of the presentation. So combining trab with phaco possibly reduces its surgical success rate. I also forget to mention there are some studies, although they're less in number, that suggest that trab alone and phaco-trab are equal in terms of success. Data on combining phaco with DS is limited, but whatever reports we have suggest that there's no significant effect on phaco on lowering the success of DS. There's only a single report with Baerveldt that suggests that Baerveldt has a lower success rate. However, there is an inclusion bias that may lead to this outcome. And finally, in a minority of glaucoma patients undergoing simultaneous cataract and glaucoma surgery, a myopic refractive shift might be introduced. So, moving on to this. On the 1-year outcomes of phaco ECP.
Basically, the conclusion was, most patients need medication, and they do quite well.
I remember reading that study a couple of months ago. Did you? But I don't recall that you looked at the refractive outcome.
That's not refractive outcome, that's the IOP.
IOP.
We have another study which will talk about a refractive outcome, and as you correctly stated, if you do trabs with, not ECP, but trabs with phaco, this was about 10 years ago, I think, when it really doesn't change unless there is hypotenuse.
Mm-hmm.
Pressure to the, I can't remember what the number was, it was 8 or 9, you get a myopic shift in those patients. Otherwise, it doesn't matter.
Actually, an area of potential future research is looking at how to calculate the IOL given the glaucoma factors in place. There's not so much data on that. One can do research in that arena. Okay, so now I'm going to be talking about sequential surgeries, and this part is going to be divided again into 2. First, I'll talk about doing the cataract first, and then I'll going to be talking about doing the glaucoma surgery first. So let's talk about doing cataract first. First point is the effect of phaco and IOP. There's a famous saying amongst ophthalmologists and glaucoma surgeons that phacoemulsification is the most commonly performed glaucoma surgery. And this comes from the fact that phaco itself lowers the IOP. And you may think that this is only observed in patients with narrow angle, but it also occurs in patients with open angle glaucoma. There's a nice study that came out last year in the British Journal of Ophthalmology that shows that the aqueous outflow facility in patients with open angle glaucoma increases after cataract surgery. Why does that happen? Many potential mechanisms. The ultrasound probably affects the trabecular meshwork in some way and increases outflow. Other possible angle is widening of the iridocorneal angle, because there's evidence that even in open angle glaucoma patient, the angle further widens as after phaco, and some think that there's an increase in the uveoscleral outflow. But it's important to mention that the IOP reduction in angle closure is by far more compared to open angle after phacoemulsification. And this is a nice shine-plug image from one of the studies that shows the pre-op and post-op angle photos after phacoemulsification in angle closure and open angle glaucoma. And you can test it in one of your patients. We have a nice Cassia machine over here. You can try in one of your patients, do an angle scan before and after phaco and see how the angle deepens. I remember having a patient a couple of weeks ago, pseudoexfoliation. The AC depth in both eyes was 2.2 millimeters according to IOL master. And when I underwent phaco and for some reason the IOL calculation was repeated, in that eye, the AC depth in the IOL master was actually 4 millimeters. So that was a significant change. Second point to talk about is, okay, we did the phaco, pressure lowering is not enough. What about doing future glaucoma surgery in an eye that's pseudophakic now, not phakic? Well, people have speculated that patients that are pseudophakics are more prone to glaucoma surgery failure compared to phakic. Multiple possible explanations. That's conjunctival scarring and previously large incision cataract extraction. Some say that there's an alteration in the blood aqueous barrier and there's an increase in the amount of aqueous inflammatory cytokines. And it's important to cite the outcome of success in the TVT study and the pseudophakic eyes only. The rate of surgical success in pseudophakic eyes at 5 years in the TVT study was 74% in the tube group. The overall success was 70% in the TVT study, in the tube group of the TVT study. And in the trabeculectomy group, it's 41%, and the overall success of trabs and the TVT was 53%, and I'm talking about 5 years outcome. And this is a nice quantile blocks plot that shows higher level of inflammatory cytokines after removing the cataract in glaucoma patients. So in this study, they looked at phakic versus pseudophakic glaucoma patients, both open angle glaucoma and an exfoliation glaucoma. And this box plot looks at the levels of aqueous humor levels of interleukin 8, and this box plot looks at the aqueous humor levels of monocyte chemotactic protein 1. So you can see that there's a statistically significant difference between phakic and pseudophakic, and actually patients in the exfoliation glaucoma group had a bit higher level of inflammatory cytokines. It's probably from the pseudophakia or from this exfoliation maybe itself. So an important take-home message from this graph is that pseudoexfoliation with pseudophakia is probably has more levels of inflammation compared to pseudophakia with open-angle glaucoma. And there are also studies saying that this is not transient, it's actually long-term. Some studies have looked at the level of inflammatory markers in pseudophakia after 1 year or 2 years after surgery, and there's still a difference. Okay, so look, from what I've said, you would think that doing a trab and a phakic compared to a pseudophakic patient will have a different outcome. And the studies in this regard have variable results. This is a retrospective report with a small number of patients, about 23, 24, that compared trab and phakia and pseudophakia for 2 years, and it showed that both groups had similar outcome. However, and let's not rush, another study with a better design and a larger number of patients. This is a prospective clinical cohort that was published in JAMA in 2014, and they found out that pseudophakia has less success compared to phakia in 2 of the success criteria, A and B, which were pressure of less than 21 and pressure of less than 18, but not for C, which is a pressure of less than 15. The p-value was close to significance, but it was 0.1. And in their conclusion, they state that if they had a larger number, this difference would probably have been statistically significant. Interestingly, again, there's no studies that compare tube and phakic versus pseudophakic patients. So it would be interesting to take a look at that.
Interesting thing to notice in that graph, if you look at where these major rates occur, typically around 4 months. That's where the peak happens.
Yeah.
4 months before. All of them are around.
And also here, yeah.
If you go back way in the 80s, I think 80s and 90s when they did papers, the statement is there based on, again, large retrospective studies. if a trap, I mean, a trap pseudophakic survives for 6 months, then you're good. The rest of the long time.
This is what we'll actually come to in the upcoming couple of slides.
There's something to point out.
Okay, now we'll take a look at it from the other way. So let's take a look at glaucoma surgery first and what effect it has on cataract progression. As we all know, glaucoma surgery accelerates cataract formation, and there are multiple mechanisms that you can think of. Steroid use, some say that's there's diminished aqueous delivery to the lens itself, shallowing of the AC, mechanical injury, and some hypothesize that there's a direct toxic effect of mitomycin on the lens itself, although I didn't find any studies that support this hypothesis. I'm not sure if there are any there. So what are the risk factors? And this is a very important line. We want to know what are the patients, or whom are the patients that are prone to develop cataract after glaucoma surgery, and those are findings from the SIGITS study. Patients with cataract at baseline, use of mitomycin C, and older age with diabetes and hypertension and a diagnosis of exfoliation are more prone to get cataract after glaucoma surgery. And this is a nice graph from one of the SIGITS reports that compares the incidence of cataract in the surgery versus medicine group. So surgery in red, medicine is in black. And you can note that it's about double the number. I think the probability is written here. Yes, it's 22% for surgery and 14% for medicine. And this is also true for tube surgery. This is from the ABC study. This is the incidence of cataract over 5-year period in, of course, phakic patients. And you can see that both Ahmed and Baerveldt have an incidence of about somewhere between 40 and 50%. I wanted to collect more evidence, so I dug into the major glaucoma studies, and I summarized all the incidence of cataract from all those studies, or most of those studies, and those are divided via trabeculectomy, via procedure, trabeculectomy, deep sclerectomy, tube surgery. We can see from trabeculectomy, SIGITS, TVT, and AGIS, it's about 19% to 56%. AGIS reported results at 7 years, not 5 years. Tube surgery from the TVT, AVB, and ABC, it's 65, and here for Ahmed and Baerveldt, 32, 41, 49, and 44. For deep sclerectomy, it's 22 and 17% at 5 years, but let's not jump to a conclusion that deep sclerectomy is less cataractogenic compared to trab and tube, because those are retrospective studies, and data for trab and tube, those are very well planned and designed randomized clinical trials. So even the definition of cataract progression is different amongst those studies. Some say that it's cataract requiring surgery, some say it's progression of 2 grades of the lens opacity classification system. So difference in estimating cataract progression may introduce a bias in comparing those percentages. Okay, so now we'll talk about the other point, which is the point that Dr. Deepak alluded to a couple of minutes ago. So if you have a glaucoma surgery and you do phaco, what's the effect of the phaco on that glaucoma surgery? And there are studies that have shown that phaco in a patient with a prior trab affects both the morphology and function of the bleb itself. And as Dr. Deepak just mentioned, the longer the period between the trab and the subsequent phaco, the better. Compared to trabs, although phaco in eyes with prior tube surgery may cause mild escalation, as we'll see in the upcoming slide, in glaucoma therapy, evidence suggests that probably tubes are more resilient to phaco, although there's limited evidence on that. This is one of the nice papers that demonstrates how the bleb looks before and after phaco. It was published earlier this year in the Journal of Glaucoma. So this is before phaco, this is anterior segment OCT, before phaco and after phaco. Don't bother much about the colors, just focus on the blue color. Blue is the fluid within the bleb, and green, yellow, and red, this is different types of reflectivity demonstrating conjunctiva and tenon and fibrous tissue, but blue demonstrates the amount of fluid. So if you compare this blue with that blue, you can notice that after phaco, there's a less amount of fluid and it's localized, and the wall is a bit thicker as compared to here where it's a bit diffuse. I'm not sure actually how far this is from that and when was the phaco performed as compared to the initial trap. But this in general gives us an idea that the morphology of the bleb might change after phacoemulsification. And this is a study that looked at 122 eyes post-trabeculectomy, and they divided them into two groups. A group that did phacoemulsification and another group that didn't do. And we can see there's about 20% reduction in success rate, and then it fairly stabilizes over time. And this occurs about in the initial couple of months after surgery. This comes from a study in Archives in 2012 and actually emphasizes the point that Dr. Deepak just mentioned. They looked at the relation of, don't bother about the busy table, they looked at the relation between the time from trabeculectomy to phaco to the outcome of subsequent phaco on trabeculectomy itself. And when they assessed the reciprocal time to cataract surgery in a COGS regression analysis, they found out that the farther the time, the better the success rate. So after 6 months, the hazard ratio is 3, so the patient is 3 times more likely to develop failure. At 12 months, 1 year, it's 1.7, and which is the result displayed here. This is at 1 year after phaco. And then if you look at 2 years after phaco, it's actually lower than 1.7, it's 1.3. So the take home from this study is that the further you are from the trab, the better. But the most significant period is the first 6 months where the hazard ratio is 3. Okay, so we've demonstrated that the morphology and function of the bleb is reduced after doing phaco. What about Ahmed implant? Again, there's limited data on that. There's a small study that comes from Korea that looked at 13 patients only, and they found out that after phacoemulsification, the pressure rises a little bit, and after adding some medications, the pressure goes back to levels that are more or less comparable to baseline. They had 13 patients in this study, and none of them were classified as failures. 7 out of 13, which is about 50% of the patients, did not require any change in medications. 1 patient required 1 medication, and 5 patients required 2 medications. And their conclusion is that phaco on a previous Ahmed might escalate glaucoma therapy in a small subset of patients. And while I was reading this paper, what came to my mind is to look at the effect of phaco on the fluid above the plate. Just like the morphology study that we looked at on anti-segmentosity, you can do a study on MRI or UBM or whatsoever, looking at the fluid before phaco and then subsequently after phaco on an Ahmed implant. This is a good idea for whomever is interested. Last, the cost. I'm not an expert in cost analysis, especially when we want to read some results and apply them over here. There's limited data on cost in Saudi Arabia, and this is a paper from glaucoma that actually talks about angle closure, not open angle. This is the only study that I'm going to cite today talking about angle closure. But what I want to say from this slide and from this paper is that in patients with angle closure, this is a study that looked at cost in different countries, China, Hong Kong, and even the States. Combined phaco-trabeculectomy is a more cost-effective option for lowering IOP compared to separate surgeries. And I think this also applies to patients coming to us from very far away. It's difficult for some patients to attend for multiple visits post-op, so it's probably more convenient to the patients and cost-effective to the institute to do both surgeries at the same time. Okay, so let's summarize the findings on sequential surgery. Performing cataract extraction in glaucoma patients may offer some IOP lowering. However, future glaucoma surgery in pseudophakic patients will have a lower success rate, particularly trabeculectomy. Other procedures, we don't have evidence. We don't say no, but we don't have evidence. Standalone glaucoma surgery in phakic patients leads to progression of cataract with a higher risk of old patients. patients that are with diabetic and hypertensive, those with cataract changes at baseline, and pseudoexfoliation patients. And finally, phacoemulsification in patients with prior glaucoma surgery escalates IOP level, and this effect is more profound following trabeculectomy and to a less extent after tube surgery, although, as I alluded to earlier, we still lack data on tube shunts. Conclusion. So, in conclusion, what I'd like to say is that cataract and glaucomas are two roads, but they eventually merge into one. Therefore, if you're putting a management plan for a patient, you should take into consideration both conditions. Some usually say, let's get rid of the cataract and then deal with glaucoma, or let's do the glaucoma surgery and then deal with the cataract. I don't agree with that statement. Simultaneous surgery could be a more cost-effective option. However, it may jeopardize the success rate of glaucoma surgery, and it has a higher chance of post-op refractive surprise compared to sequential surgeries. Pseudophakia, which is cataract first, lowers the success of sequential glaucoma surgery, particularly trabeculectomy, and on the other hand, glaucoma surgery first in phakic patients can lead to cataract progression, especially in those with high risk features at baseline. Nonetheless, sequential surgeries, depending on the urgency of either condition, would offer a more predictive outcome, especially when you have the luxury to space both surgeries wide apart. If you're doing the trab and then phaco after a couple of years, that would be better. Again, in order to change our common sense, we need further research to improve our knowledge base. So for those of you that weren't here at the beginning of the presentation, I presented a case and I took a vote. My plan was to see if the presentation changed the mind of some of you. So now in the conclusion, we'll take the vote again, and we'll also ask people that came late. So the case was a 60-year-old male with primary open-angle glaucoma. Acuity is 20/50, pressure is 21 on full topical medications. Cataract is nuclear sclerosis +2, cup-disc ratio is 0.9. What's your preferred surgical approach? Phaco plus minus mix. Glaucoma surgery, and by glaucoma surgery I mean trab, DS, or tube. Phaco plus glaucoma surgery. Now you cannot be unsure, you have to decide. So I'll give 10 seconds for those that came late to think about the question, and then we'll take the vote from everyone. Let me just go to, or let's take the vote first, and then bring the numbers from the beginning. Good seeing eye, 20/20 vision, pressure is okay. Yeah, 0.5. Okay, let's take the vote first, and then I'll bring the numbers that we illustrated in the beginning. Who votes for phaco plus minus mix? Raise your hand. 1, 2. Ibrahim, your hand is in the middle. With or against? 2. Okay. Glaucoma surgery? 1. Phaco plus glaucoma surgery, I think we have more. 1, 2, 3, 4, 5, 6, 7. Although the number between pre and post presentation question are different, but let's just I guess the majority, this is before presentation, this is after presentation, majority agree that phaco glaucoma surgery is probably the best option, of course, because I guess the glaucoma is advanced. Consider. Yeah. Exactly, yes. Visual field progression, target IOP. Actually, when you look at the studies, they try to control all the factors and look at one variable. When you come to clinical practice, you have lots of variables in which if you want to compare your patient to those studies, you cannot because it doesn't apply. But as we said, we're just going through these things just to improve our knowledge and potentially improving our patient care. So, okay, we went through all the evidence, and this is my last slide. What next? My comprehension of this presentation may differ from Ibrahim's comprehension. Yesterday, Ibrahim and I were discussing an issue which is what glaucoma surgery would you prefer in a patient with a corneal graft? One of us was saying, okay, I'll do CPC because CPC has a less incidence of graft rejection and failure. And then another one was saying, no, I'll do tube surgery, although it may have a higher risk of rejection and failure, but it will provide the long-term control. And we read a meta-analysis together yesterday, and they found out that the risk of rejection and failure in patients with a graft is 20% with CPC and 30% with tube. And even after reading that result, each one of us, looked at it from a different perspective. One said, okay, I'll do CPC. The risk of rejection is less. The other said, no, I'll do tube surgery. I'll take the risk of rejection, but at least I'll provide more long-term control. So even after reading those results, our opinions are different, which is totally normal. I'd like to present my understanding of whatever I presented and an algorithm that...
I think a lot of us who are a little older in the audience, there are a lot of crowds in the early 80s
with grafts.
Dr. Benak can comment on it. I don't think they were too bad.
Exactly. So that's what I'm trying to say. So we...
Limited access to tubes.
Mm. Mm.
We had a good graft.
Good grafts, yeah. Yeah, but what I was also trying to say that we read the studies and we know the evidence, not to apply it as it is to our patients, but it allows us to better understand. There's actually limited data on advanced open-angle glaucoma. It's been a long time since the ages. It's about 20 or 30 years. At that time, people are not even using mitomycin C. So we still don't know much about how to best deal with patients with advanced open-angle glaucoma. And this is an important...
Physics gives you a fairly good evidence. Population is very similar, but that's only trabeculectomy.
Yeah, exactly. So what about trabeculectomy versus... One thing I was thinking of, okay, that patient that initially presented with advanced glaucoma and significant visual field loss, will tube surgery offer a more fairly controlled and more stable visual field compared to a trab or not? We know that trab might give some progression in visual field. We don't know. And this is a significant area that needs improvement in terms of research. There's a study that started in Britain last year, I think, 27 centers, and they are looking at, it's called the Advanced Glaucoma Study, AGS, and they're looking at patients that present late, which are the typical KCASH patients, what to do first, medical therapy versus surgery. And the results of that trial, when it comes out in a couple of years, will help us in better managing the patients that come to us. Because sometimes you have a patient with advanced glaucoma, pressure is 12. Shall I do surgery or keep him on whatever he is? This is a usual question. So going back to the presentation, this is my understanding, and this is how I would advise my patients in terms of management. If he has advanced open-angle glaucoma, lens is clear, the equation is probably simple. I'll do a DS or a trab. If the lens has cataract, question is it visually significant or not? If it's visually significant, is the IOP close to target or is it far away from target? If it's close to target, I'll probably do a phaco mix and not bother about the complications of a phaco plus major glaucoma surgery. If the IOP is above target, just like, for example, our patient, I'll probably do phaco with a glaucoma surgery. Our patient had 21. I didn't point out the target in the question, but I guess in my approach, the patient that I illustrated falls within this category. What about early lens changes? Well, in my perspective, according to the baseline risk factors that I alluded to earlier, early lens changes is one of them, but if the patient is diabetic, old, pseudoexfoliation, I'll probably even try to convince the patient to do simultaneous cataract extraction if he's interested. And I'll do a phaco combined with DS or a tube. If he's not interested at all, this is the least common scenario in my point, because I usually try to counsel the patient about the risk of cataract progression if he already has some lens changes. And if he's not interested, I'll do glaucoma surgery alone. I'll probably be more inclined towards a tube. You may not agree with me, but if I do a tube and then I'll need a phaco later, a tube will probably be more resilient than a trab. What about if the patient is pseudophakic? If the patient is pseudophakic only, I would probably still do a trab. But if he has other risk factors for trab failure, let's say age, race, previous failed trab, I would do a tube. But if he doesn't have any other risk factors, I would probably still do a trab and DS. And probably some of you may not agree with this. That brings us to the end of the presentation. I'll keep this slide if someone wants to comment. And then if anyone has any questions, we can discuss further. Thank you for listening.